Good morning, everybody. I'm Kavinda. First of all, I thank everybody from the KSM and the supporting staff for giving me the opportunity to deliver the lecture for you all. So it's about common eye conditions and how we approach it practically. So the objectives or aims of the lecture is to identify the common eye disease and presentation, and to discuss the management, and to identify the ocular emergencies, and to identify uh, the patient for the general ophthalmological referral to refer to the eye clinic. To understand this lecture, I will just go through anatomy and physiology revision, and then I'll be talking about these lectures briefly within the next 40 minutes. Tearing, trauma, squints, corneal ulcers, red eye, refractive errors, glaucoma, retinal detachment, diabetic retinopathy, hypertensive retinopathy, central retinal vein occlusion, chemical injury to the eye, and investigations we do. And at the end of the lecture, you can ask questions. So, coming to the anatomy, so if you take the eye, the upper lateral part of the eye is where the lacrimal gland is, and that produces tear. With the blink of an eye, with the blinking, the tear spreads down and towards the medial side, where it is collected from the punctum, to punctum. That's the lacrimal drainage system start. Then lacrimal canaliculi, then goes to the lacrimal sac, goes to the nasal cavity. And the next slide is about uh, how we see the eye from the side. And you have the lids, and lid you have anterior lamella, which consists of skin and orbicularis muscle, then tarsal plane, conjunctiva is the posterior lamella. Then I'll go into more detail the next slide. So if you look at the eye, what you see is the pupil in the center, and that is the gap between the iris that goes 360 degrees, and it's like a camera's aperture, which allows the light to come inside. And if you, so the front part is the cornea, which allows the light to go through. It's here, and then you have the between the cornea and the iris is the anterior chamber, and between the iris and the lens is the posterior segment. The whole thing is called the anterior segment, and the rest of is called the posterior segment, which contains the vitreous, which has the gel, and then there are layers. This is the retina, which focuses the light and which is supplied by the choroid. Choroid is a uveal tissue which starts from the iris in front, ciliary body, goes back up to the optic nerve, and which is covered by the scleral coating, which is the connective tissue component. And eye movements are controlled by the extraocular muscles. So you have here the recti muscle, superior, inferior, lateral, and there are two obliques as well. Physiology. So there's fluid inside the eye. In the anterior chamber, the aqueous is produced in the ciliary body. This is part of the uveal tissue behind the iris, and it comes down in front of the lens, between the lens and the iris, and goes around the iris and drains into the angle between the iris and the cornea, which is the angle of the eye. And then there are trabecular meshwork which absorbs, and then it's drained to the scleral canal, which is taken out of the eye. The aqueous humor, or the fluid inside the eye, is non-toxic. It's similar to BSS, balanced salt solution. And we have these blood ocular barriers to make the eye transparent. So if you have the blood coming through, then you won't be able to see anything. So there are blood retinal barriers and blood aqueous barriers. So blood retinal barriers, you have the retinal pigment epithelium, which is the deepest layer of the retina, which doesn't allow the blood to come through, because you have the choroidal tissue, part of the uveal tissue behind, which is highly vascularized. And then in front you have the retina. You also have the retinal vasculature, and it has tight endothelial junction. It doesn't allow the blood to leak through. And in the anterior chamber also you have the uh, uh, retinal non-pigmented epithelium, which doesn't allow the fluid to leak through unnecessarily. And coming into the condition, you will come across children with tearing and very young age, as well as when they grow old as well. And then it goes on to adults. Sometimes adults also come across with excessive tearing, which is called the epiphore. So what is the reason? It's kind of a problem with the lacrimal drainage system. So it's kind of a block in the nasolacrimal duct system. So the child will be having tearing like this, and you'll see the lacrimal outflow system from the punctum going into the canaliculi, lacrimal sac, and going into the nasal cavity. And there are some valves, inborn valves inherently placed at certain parts. The most important is the valve of Hasner, which is down here. And when the child is born, these valves are not functioning properly and kind of tries to block the normal drainage. It is physiological. In the first year, they open up. So if they don't open up, what we tend to do is like to apply pressure. So how do we apply the pressure? First, what we have to do is like you need to have pressure over the lacrimal sac. So from the eye side to the nasal side, just press over there. Then you build up pressure inside the lacrimal sac, and then you squeeze the finger down. So that would take the pressure from that system into the nose, which will open up the valves. And with time, when you do it regularly, the valves will open up and it will stay open. So how you manage it? You ask the healthcare worker or doctor to advise the mother or the caregiver to massage down, and if necessary you can give an eye ointment if there's a discharge. Physiothalamic is safe, and you have to reassure, because always with children parents are a little worried, and you have to review once in a way, because your diagnosis might be right or it might be wrong. If it is not resolving, you have to refer the patient to the ophthalmologist. And ophthalmologists also wait for a year or so, and if it's not resolving, they do the probing. They put a probe, like canalicular probe, and then inject fluid, and that pressure, that jet of fluid going through will open up the valves. Still, if it doesn't open up, then we have to resort to surgery. So other important causes of child neonate tearing is congenital glaucoma with high eye pressures. The corneas tend to be larger and it might lead to blindness. So you have to keep an open mind about the other possible etiologies. And other one is the neonatal conjunctivitis. This is kind of the other spectrum. Usually they are not this bad. Then acquired blocks, which happens in the older people. This is something not physiological, or it happens later. Commonly, after an infection, there is kind of blockage of the nasolacrimal system, and first we can give it topical antibiotics and steroids, and then can resort to saxarin. So saxarin, the sac, you inject fluid into the system, and they will the fluid will come through the nose, and the patient will tell that it is coming through the nose or the throat. And it might lead to a dacrocystitis, that is an inflammation of the lacrimal sac, which can give rise to preseptal cellulitis or kind of cellulitis, which in turn, if it breaches the normal anatomy and physiology, it can go to the orbital, through the orbital septum. It can give rise to an orbital cellulitis, and it can give rise to infection in the brain as well. So this generally doesn't happen because the anatomy is intact. Rarely it can be due to imperforate opening or the lacrimal canaliculus opening not happening. Trauma. So generally in children it's difficult to, because the children, they don't come up with the history or they don't explain. They come up with tearing or irritation, and it can come up with anyways, sometimes rocks, branches of the tree, and it can be a blunt or a perforating injury. And children, sometimes they present it a kind of a red eye with a subconjunctival hemorrhage. That is a kind of a redness over here. It can be a little more extensive. It might be associated with corneal lacerations in the cornea, and traumatic uveitis. The uveal tissue, including the iris, can get inflamed. Sphincter damage. The pupil remains round. When it's damaged, you will have non-rounded pupil, a little dilated as well. And lens, which is behind this, can become subluxated. And in the retina, you can have retinal tears, vitreous hemorrhages, and if in a blunt trauma, because the optic nerve comes through a canal, and it can give rise to traumatic optic neuropathy, which can be permanent. So what happens in a blunt trauma? When the force comes from the front, the globe is kind of a compressible, decompressible chamber which inside the orbit. It pushes the cornea inside, and the volume suddenly expands, moves this way, and suddenly there's a decompression, like a bomb, like what happens when a bomb explodes, same thing. And then it gives rise to all these problems. So this is a photo. It's not very clear. It's anti-chamber inflammation, and this is a traumatic where you can see the sphincters have been damaged over here. And hyphema is blood in the entry chamber. You can see the blood, and you can see the subluxatedness. The lens should be somewhere around here. It has moved to the side, so it doesn't give the necessary refractive correctiveness. And this is traumatic damage in the retina, which is called commercial retina, where the retina looks pale. And sometimes children or sometimes adults, they refuse to open the eye for examination, so you don't know what's happening. So you have to think of the worst case scenario, possible globe rupture. Therefore, don't put pressure on the globe, and gently clean the eyelids, and don't try to pry open, but then use a device which is safe. It doesn't push on the globe to open the eye. If the patient is allowing, you can gently open the lids, and then you can add a preservative free antibiotic, because the preservative, if it goes inside the antechamber, then it's toxic. And it's important to send to the ophthalmology unit when the patient kept fasting for the surgery. And the important thing is, from peripheral unit, sometimes getting an ECG at a certain time of the day might be difficult, so if possible, send with an ECG as well. Another cause of persistent pain and irritation in the eye can be due to a corneal epithelial defect or corneal or conjunctival foreign bodies. You can see there can be tiny specks, which is lying under the lid, which is not visible. You have to invert the eyelid to find those. It's a metallic foreign body, which is not so common. People traveling in the trains, these metallic parts coming and lodging in the eye, and they disappear underneath the lid and keeps the eye constantly irritated. It's corneal foreign body. And this is the appearance of the cornea. It's not very clear, but then the cornea anterior surface is very hazy, and this is a persistent epithelial defect which is stained with the fluorescent. How to invert the eye? First, this is an important thing, like if your child or somebody at home, happens to have a constant irritation, just grab it from the eyelashes and just pull it a little down and ask the person to look down and put a cotton bud over the place where you are going to turn. It's like the fulcrum, right? And then push it down at the same time, pull the edge of the lid upwards, and you can divert the lid like this. Takes a little bit of practice, but then it's not too difficult. And delayed presentation can give rise to a corneal ulcer. Ulceration, normal ulcer definition is like it's little different in ophthalmology from the normal pathological definition. Here, just the epithelial damage, we call it an epithelial defect. Corneal ulcer is underlying stroma is also undergoing necrotic changes, and this is an emergency for ophthalmologists. The important thing is like not to prescribe steroids if you are not too sure. It might give rise to a ulceration which can impair the vision permanently, and generally like the fungal and the viral ones can progress with very quickly with the steroids. And this is what you call hypopyon, the pus collection inside the entry chamber, and then possibly the bad cornea. You might have to do a corneal graft, and the patient is on lifelong treatment like a normal graft. And here the treatment, like they advance the conjunctiva and try to cover the corneal ulcer. Sometimes tarsarophy or just closing the eye, and sometimes the conjunctiva closing the defect, with time will heal the corneal ulcer. It's important to avoid combination of steroids with antibiotics unless you have stained the eye and examine the eye under the slit lamp, including the cornea and the subtarsal, that is everting the eye and see. So conjunctiva, this is the commonest cause of red eye. There's a diffuse conjunctival hyperemia, and the cornea is clear. And if you see rather than the area surrounding the cornea, the fornices are more red. That is a hallmark of conjunctivitis, right? Corneal ulcer, you have a more around the corneal redness. Uveitis also has we call it the ciliary injection. This is the ciliary, where the ciliary body lies. So the injection is more, or the redness is more around the cornea in uveitis and corneal ulcer, where conjunctivitis is more the fornices. And scleritis and episcleritis. You have the sclera, and the layer in front of the sclera is episclera. You can have the episcleritis and scleritis, which are associated with autoimmune diseases. It can be diffuse or segmented. And this is an episcleral nodule. Trauma is associated with subconjunctival. It's another cause of red eye. Blepharitis is inflammation of the lid. Sometimes the lid, the posterior margin or anterior margin is inflamed, which rubs on the eye, which causes a red eye. Any cause of irritation like entropions, which is the turning inside of the lid towards the cornea, towards the globe, or ectropion, where the lid turns away from the globe, can cause to dry eye and redness. Also, trichitis is the abnormal direction of the eyelashes towards the cornea. Conjunctivitis can be infective or allergic. Infective, the viral ones are the commonest, and bacterial ones are common in children, especially with sinusitis. The difference between infective and allergic is that infective, it's more associated with the itching, irritation, grittiness, redness and soreness is much more than the allergic, and it's of a shorter duration and can associate with pharyngitis, fever, or preauricular lymph nodes, whereas allergic ones have more itching, more commonly in the younger population rather than the adults, and these are subacute or chronic, which last for like a longer period of time, and discharge is mild. And infective ones, you have a more of a diffuse conjunctive inflammation and subtarsal, that's underneath the tarsal plate. There's some papillae and follicles, sometimes membrane formation, keratitis, the corneal inflammation, and they generally don't progress into perforated ulcers, but some they do, like gonorrhea. Allergic ones can give rise to subtarsal giant papillae, and also in allergic they have this peripheral inflammatory aggregates called hornet and rust dots and shield ulcers. These large papillae put pressure on the cornea, and they have a kind of a ulcer due to pressure. So this is like the papillae, and this is the membrane over the conjunctiva. It's not this thick, generally it's kind of cellophane like thick. This is the keratitis. Can you see the small dots over the cornea? These are the hornet and rust. Those are inflammatory uh, uh, aggregates in the limbus. This is the periphery of the cornea. Right? And this is a shield ulcer. Shield ulcer is something underneath here which is pressing on this, and it's not an active ulcer. Mostly it's viral adenovirus, which is highly infectious. Generally we use antibiotics. Everybody uses antibiotics, and it's very common for you see pediatric population also. For every condition we give antibiotic, but somehow they get better. Like possibly the reason being all antibiotics have an anti-inflammatory effect as well, which is not widely spoken about. So possibly that also helps. I don't know. Anyway, avoid steroids unless corneal epithelial defects are excluded. So if you have corneal epithelial defects, if the fluorescein is staining, don't put steroids. Rubbing causes more defects and ulceration. Important thing is to prevent cross infection. Whenever you touch the eye, always wash your hands, and also the places where your eye can touch. And if you touch, generally what happens when you touch the eye and you touch this place, and somebody touches this place and rubs this eye, that's how it, rather than airborne spread, that's direct contact spread is the common for the conjunctivitis. So always wash the hands. So kind of a treatment algorithm. You can start with an artificial tear 4 times daily for like 3 days, and if needed you can add an ophthalmic ointment. If it is worsening, pseudomembrane formation, reduced vision, discharge is much more, then you have to suspect bacterial conjunctivitis and start an antibiotic, and you have to review frequently. And if it's not improving, I would say 2 to 3 days time better to send to an ophthalmologist. And if it's improving, you can continue whatever you are using, but always keep an open eye about what's happening. Adenovirus keratitis, you can start lubricants, and also add fluoromethanol is a very mild steroid, like 4 times daily, and can gradually tail off. Then you have to continue the tear supplement, because always conjunctivitis is associated with the kind of a dryness which would last for a month at least. And since you are using steroids, especially in children, monitor eye pressures. Children they don't allow, but then they have air puff tonometers in the pediatric eye units. Once the epithelial lesion stops staining with fluorescein, the infection is settled. The scarring underneath the epithelium will take a longer time to settle, and they might recur as well. Then we'll move on to the squints. Right? Squints, you use different terminology. If it is turning in, we call esotropia. Turning out, exotropia. Hyper is up, hypo is down. So important thing is when you notice a squint to refer, right? And we do different tests, and it's important to examine carefully and to do a dilated fundoscopy, and to make sure there are the refractive errors are correct. Orthoptic assessment is the squint assessment by an orthoptist, kind of a specialized optician. Why it is important to dilate fundus? In children, you see this red reflex and the white reflex. Um, it's not so uncommon, the retinoblastomas, to present with squints. Surgery is not always necessary. There are some refractive correctable squint types. And correcting amblyopia. Amblyopia is like because of the squint, or if you are of the refractive error, one eye is not seeing well and the image does not focus well, and with that the brain has become a little lazy in identify the vision, so the patient won't have six vision. So that you have to correct by correcting whatever the squint and the refractive error and patching the other eye to make it to stimulate this eye. That could be done in children. And types of refractive errors: myopia, which has the people wear negative kind of lenses; hypermetropia, use plus lenses; astigmatism, where you have a refractive error in a certain meridian of the eye; and presbyopia, it's kind of a like like we used to say, but it's not a true wording. We'll get to that. So normally what happens is the light comes in from the infinity, comes and focuses on the retina, right? And this one focal point and gives a clear image. These are the angles that we talk about: meridians 0 to 180. And emmetropia is when the light focuses properly from the myopia is like it focuses in front, so that you have to give a negative lens. Avatala kannadi. Then it goes and focuses here. And hypermetropia goes, the eye is kind of a small, these eyes are like a long, then focus behind, then you have to give a powerful plus lens or uttala kaja to focus it properly. Astigmatism is like you have this horizontal and vertically, because eye has a shape of a rubber ball, both vertical and horizontal might not focus on the same place, right? And then one meridian or one angle you might need to add a power. That's an astigmatic error. So it's like this, you add this thing, and then this the light coming from this vertical side, then we help it to focus. So this is how it comes. This is a spherical error, that is the main plus or minus error. Then cylinder with axis is the astigmatic error. We have the axis and the power, and this is how it comes. And then you have this addition. Addition is like presbyopic. You add another additional power to see the near, because all the other power is for the lights coming from the infinity to focus. Children, it's important to assess the dilated fundus at least at the beginning to make sure there's nothing else wrong apart from the refractive error. And you do a cycloplegic refraction, because cycloplegic refraction, you relax the ciliary bodies because they have high accommodative powers. Accommodation is like the ability to change the focus from the distance to near. Children can see very near things, whereas adults can't do that, and that ability is much more in children, and they grow very fast, and then the refractive powers also change. And it's important to instill healthy habits, but nowadays you'll see lots of children with refractive errors because they are more into the devices because of the COVID restrictions which happened in the past. If the child changes the spectacles very frequently, there might be something else as well. So you can give glasses, you can give contact lens, you can give laser refractive surgery, which is called the LASIK and LASIK, which you do when the eye refraction does not change. After a certain age, like 21, 22, you have to wait for a LASIK surgery. Presbyopia correction. As I told you, the crystalline lens, which the normal lens, which has some refractive power of 15 diopter. Like you can change that much of dioptric power. When we gradually become older, that ability lessens. So generally, like a small child can look something like this close, but that ability when you grow up, like at 20, that is around here, 30 around here, 40 around our working distance. That's why at 40, that if we happen to read something like this close, we will be presbyopic at 25. So it's kind of a doesn't happen at the age of 40. That's a misnomer. So it is gradual process, and that at the age of 40 is our working distance. So that's why it happens at 40, not because suddenly something changes at 40. And moving on to another corneal or refractive condition, it's called keratoconus. It's kind of a corneal thinning or corneal ectasia. We have collagen molecules which allow the light to go through, but they are not strong enough, they are not cross-linked enough, therefore they become progressively thinner and giving rise to refractive error. Initially they can use spectacles, but then the rate of changing spectacle is remarkable. Like every 6 months they change the glasses, but then they have to go on for special rigid gas permeable contact lens, and then at the end point they might need a corneal graft to salvage. So it's important to catch them early, because by treating you will stop the progression. So this is the image. This is normal cornea. This is what happens when it thins out. And this is a complication. The fluid has leaked into the stroma of the cornea, and it is a corneal edema. It's kind of a corneal scarring process. The important thing is, like when you reach the age of 30 to 35, it's the maximum corneal stability happens. It's maximum cross-linking. Eye rubbing makes it progressively worse. So if you happen to have it starting at a very young age, the progression is faster and the prognosis is poorer. So it's important to catch it early. So prolonged cross-linking, you use UVA light and riboflavin, and then we apply it over a certain period of time. That makes the corneal cross-linking faster. So aim is to make cornea as stronger as the age of 45, and for that you have to have a certain amount of corneal thickness, otherwise the UVA will damage the internal structures of the eye. And this is what you do generally: deep anterior lamellar keratoplasty, where the endothelium is kept intact against a full thickness corneal graft. Then going into glaucoma. Glaucoma is a progressive optic neuropathy. This how we see normally. Then when glaucoma progresses, you end up with tunnel vision, and then you might get totally blind. It's a condition, one of the most commonest cause of irreversible blindness worldwide. This is how it looks. This is the retina all around, which comes and goes into the optic nerve, and in the center this is a hollow area, right? Then when these things damage, the hollow area becomes bigger. That's the cup against the disc. So the more the cupping means can be physiological, or progressively the cupping becomes large means the optic nerve and the retina is becoming thinner. So from like this is what you call like 0.1% cupping, this around like 0.6, then this around 0.9. So this is very little area. This is the hollow center. This is the neuroretinal rim, which is very thin, which is associated with visual field defects. So treatment, you can give medicine or surgery. Beta blockers and prostaglandin analogs are kind of first line. Prostaglandin analogs are better. Beta blockers, you have various side effects, and these are the other drugs you can use. Or you can do surgery, where you can bypass the normal aqueous drainage system and you drain it to the subconjunctival space. That is called a trabeculectomy, where you make a hole from the anterior chamber to the subconjunctival space and try to make it open, not to for it to close down. And this is how it looks, the trabeculectomy site. And there's another component. Generally, this chronic angle open or glaucomas, they are not symptomatic unless they are kind of very advanced. Acute angle closure glaucoma, angle closure attacks, generally they come up with very high spikes of pressure, and then this corneal edema and pain. This generally happens like when the pupil dilates and this angle of drainage becomes blocked. Especially it happens in the evenings and nights, right? And the pathology is different where the drainage is blocked. And sometimes they can come with severe vomiting, headache to the medical wards. So the medical wards can have people with acute angle closure attacks. So this is how you treat. You look for and you treat the pain with analgesics and vomiting antiemetics. You look for a secondary cause because topiramate is used for almost any neurological condition now, and that might give rise to an acute angle closure attack. You treat with carbonic anhydrase inhibitors, beta blockers, alpha agonists, and systemic drugs and sodium chloride for the cornea to become clear. And the other management include cataract extraction, treat a secondary cause like topiramate, and laser to lessen the corneal edema and to reduce the eye pressure. Flashes and floaters. So flashes, you will have this flashing sensation, especially in the darkness, and that is a very significant sign. And floaters also. If you have a floater and flashes, ask the patient to go to an ophthalmologist to do a dilated funduscopy. This might be the onset of a retinal detachment. See the retina detached, and when there is retinal traction, you have this sensation of flashes, and it's very difficult to treat. In the acute condition you can treat, but sometimes chronic, very difficult to salvage. See the tear of the retina, and you have given lace around this to salvage and to prevent it progressing further. The surgery include triport pars plana vitrectomy. You can put silicone oil inside the eye, gas SF6, and you can put an external band or pneumoretinopexy is like an expanding gas you put inside the eye. Then go into diabetic retinopathy. Get people who have a longer duration of diabetic with poorer control, with high sugars or having fluctuating sugars and with associated medical problems are prone to get it. So when you should screen at the time of diagnosis, if there's no retinopathy, if the retina looks fine annually, the pathophysiologist, the capillary leakage or diabetic macular edema, and this the endothelium is not healthy, so there's capillary occlusion, and then goes into retinal ischemia, goes into neovascularization of the retina, hemorrhages of the vitreous, then goes into tractional detachment and the glaucoma with blood vessel formation, which is very difficult to treat. And this inflammatory mediators are secreted because of the ischemia. Our main culprit is the vascular endothelial growth factor or VEGF. So we use anti-VEGF agents to control this, which reduces the red swelling, edema, as well as new vessel formation. So you can see some photographs, and here you can see the new vessels formation and new vessels around the disc, and venous beading and venous changes. And this is how it looks in the fluorescein angiogram, where the blood vessels start leaking and neovascularization has the proliferative phase as well as later on it has the like fibrotic phase. So you have mild, moderate, and severe diabetic retinopathy. Non-proliferative, then the bad thing is proliferative, early, high risk, and advanced. And then macular edema we classify as center involved, where the fovea is there, the maximum vision is at the fovea, and then the center not involved, where there can be macular edema and the vision is less affected over here. So important thing is to the ophthalmologist to see and diagnose and follow up accordingly. So severe ones you have to see more regularly, mild one and no diabetic retinopathy annually. Whereas when it comes to the proliferative stage, you can give laser and other treatment. Here you wait for it to come to this stage, and once you get here you have to treat. Right. So these are cotton wool spots which are not part of the classification but tells you that there is kind of ischemia. Cotton wool spots are nerve fiber layer infarcts. These are dot and blot hemorrhages. This are some extensive hemorrhages. This traction on the disc, and this is kind of a very bad tractional retinal detachment where the vision is not salvageable. And here also along the blood vessels you see the tractional bands, which is managed surgically. This is a macular edema, the macular edema. So you have the cyst appearance as well. And go into the hypertensive retinopathy. There are classification grade 1, 2, 3, 4. Grade 4 is severe. Grade 3 retinopathy with disc edema and retinal edema. Grade 3 is you have lots of hard exudates along with grade 2 changes with flame shaped hemorrhages. Grade 2 AV nipping and this silver lining and the copper lining is in grade 2. In grade 1 there is mild generalized constriction. There's no need of screening like diabetic. No active ocular management. Central retinal vein occlusion, there are two types, non-ischemic and ischemic, where ischemic is the worst type, where the vision is very much less compared to the other type. Apparent pupil defect is much more there in the ischemic type and more pronounced changes in the retina. Right, this is kind of extensive ischemic type, this is kind of a non-ischemic type. This is the fluorescein angiogram. Commonest causes hypertension, and all these are associated causes. So we know the Virchow's triad, so it can be the coagulative factor problems, endothelial problems, or something pressing from outside. Right. So these are all these vascular problems that can give rise, especially in a young patient with central retinal vein occlusion. We have to do this coagulative screening. If you have macular edema, then you have reduced vision, so that you have to give monthly anti-VEGF injection, vascular endothelial growth factor, and you can give dexamethasone implants for people who don't have glaucoma and people who have undergone cataract surgery. And then you do a fluorescein angiogram, see the amount of retinal ischemia, and according to you can give laser therapy. Age-related macular degeneration, there are two types, dry and wet. You can treat the wet type, which is more vision threatening, and you give anti-VEGF injections. Now we give anti-VEGF injection for almost most of the eye conditions, medical retina. And the dry AMD, we have these bruisers. These are aging products of the retinal cells, and they accumulate on the retinal pigment epithelium. So you have to stop smoking alcohol, and according to the protocol, you can give antioxidants. So this is the fluid collection with wet AMD. And chemical injury, I'll just rush through, can be accidental, assault, or with occupational. So this can involve a medical legal procedure. Make sure that you don't miss these, right? And document it properly. So alkaline is more hazardous because it erodes through the tissues and goes on to damage the deeper tissues against the acid things. Acid also makes some damage, but can damage the cornea, the lens, and everything, and the adnexia, the associated glands. And the most important thing is sometimes these particles of lime. Lime is an alkali that can lodge inside the lid and then give rise to more and more damage, because the important thing is the pH of the substance and the duration of the exposure. So the more time you keep inside the eye without noticing or under the lid, then the more damage. And the ischemia give rise to whitish kind of eye. There's no blood supply here, and this can be blinding and disfiguring. This is how it presents. So you have to always look for limbal ischemia. Limbus is around the cornea, and then if the limbus is ischemic, then the whole cornea becomes hazy. So it's important to re-establish perfusion and then to salvage the eye as much as possible. So at the onset, irrigate up to 20 minutes, or if you have till the litmus papers are neutral, you have to irrigate, right? And also make sure the inflammation is reduced, and then you have to correct the areas which are so this is a tedious process, and the visual prognosis not so good at times, and it's challenging for the patients and the physician as well. So direct jet of saline, so sometimes the things are under the, sometimes you can't evert the lid, so sometimes you can give a direct jet of saline underneath while you're washing, while you're irrigating. And sometimes you have to put an anesthetic drop for the patient's comfort, and if possible evert the lid. What we do is we do double everting. We evert and take that part of the everted part, and we do a double eversion. That sometimes even when you do those, sometimes these alkali parts and other foreign bodies can come through. And it's important to like if you can't do anything, just take a cotton bud and sweep just blindly underneath before transferring, and transfer as soon as possible. And the other concept that you will come across, relative afferent pupil defect, which is afferent. Eye has the afferent pathways and efferent path. Afferent is light going through to the brain, and efferent is the pupil constrict. So it's an important clinical sign to check the functionality of the optic nerve, right? So what we do is you check, put light into each eye and see how the pupil reacts. So it's important, like now if this pupil and the optic nerve is normal of this side, and if this is normal, say if you in a scale of 1 to 10, if you put a light of 8, then this constrict to a certain amount, and the other pupil also should constrict to the same amount, because it goes and gives to efferent supply of both eyes. And you go to this side and put a light of 8 from scale of 0 to 10, then the same amount should constrict on this pupil as well as the other pupil. And if one pupil is dilated pharmacologically or traumatically, if you put the light, okay, the optic nerve of a scale of 0 to 8, if you put a light of 8, same amount should constrict here, and since it's dilated, it should try constricting, but it might not happen. Right? You go to the other eye which is dilated and put the light, because your input is 8 and the output should be 8 here and 8 here. So the other pupil should not constrict or dilate. So that's the theory. So one pupil, working pupil, is enough to check the activity of the both eyes. So that is not very easy to demonstrate this. It's kind of, that's a concept. It's called the Marcus Kahn pupil and the reverse. For us also, it's very difficult sometimes to see whether RAPD is present or not. So what we do is we check this eye and check the other eye. If now this eye is dilating, so that eye we think it's RAPD is there, and go to the other eye. That eye should not constrict in a normal situation. If it constricts, that means this eye hasn't the afferent pupil or the optic nerve is not functioning properly. That's why when you put more light into the eye, that's why it's constricted, because from here the light goes into this pupil as well as this pupil, and while you are flashing the torch at this light, this pupil is dilated because the afferent is less from this side. When you switch to the other eye, because this side is normal, the pupil constricts. So that's why sometimes rather than looking at this side, we look at the other pupil to conclude. It's still very difficult. In ophthalmology, people fail the final exam just because they don't pick up this side. So it's kind of a important thing. Then a bit of investigation, we do ocular coherence tomography. We look into details of the retina as well as on the optic nerve. Right? Optic nerve is important for following up idiopathic intracranial hypertension, because we can see the thickness of the optic nerve head as well. With the treatment, we can subjectively assess the control, and for the macular thickness, we can, rather than we can subjectively assess. So we have the 10 layers of the retina, and each layer we can assess, because these scans have come up leaps and bounds and they are much more advanced now. So there's a central involved diabetic macular edema photograph, and you can see all these hard exudates in the diabetic patient, and these are drusen's, these subretinal exudates in the AMD. So these are the anatomical layer. With that, you keep in mind and just interpret the OCT or ocular coherence tomography. And these are in a glaucomatous diagnosis. We do both optic disc as well as the ganglion cell analysis, which is much more sensitive. Pre-perimetric diagnosis of glaucoma. It's very important. And this is in a glaucomatous patient. We have the cupping over here, especially this part is much more thinner than the rest. So correspondingly, you have a visual field defect as well as a ganglion cell deficiency. B scans are the scans, kind of ultrasonic scans, where you can visualize the retina, optic nerve, and vitreous hemorrhage you can diagnose, and melanomas you can diagnose. So when the patient doesn't see, before going on to a cataract surgery, sometimes we do a B scan just to make sure the rest of the anatomy is all right. So there are some guidelines, and the images were taken from the web and CanScape. Thank you very much.
Thank you very much. If you have any questions, it's time to ask.
I think I put too many deep details and people are confused, but it's all right. Like, you can ask any question, I'll be happy to answer.
I never thought the eye is that serious than what we see in naked eye.
That's because you see through naked eye. Lacrimal abscess. How do you brain? Do you sort of go through inside the brain?
Well, if it is pointing, then it is anyway going to rupture. So generally, what we do is we go from the outside and put a nick and drain, but that is temporary because some people are against that notion because we are creating a fistula. So what we try to do is we try not to, as much as possible, not to drain. We try to give antibiotics and try to control the inflammation and do a dacrocystocrinogrom as quickly as possible. But it's under general anesthesia that gives us few headaches, like organizing the event. But then in certain instances, if the infection is not, we can't control it, we generally go from the outside, because uh, if you do it from the inside, it's the ENT surgeon's part basically, because we have undergone training, but we are not so good at going endoscopically and doing that.
Any other questions?
How is the response when it is matured keratoconus? When it is matured keratoconus, corneography and things like that, how is the response and how is the outcome?
Well, you have this K readings, K1 and K2. Mature keratoconus is like the K readings are on the higher side, very high side. So the response is you can't go for the conventional treatment. You can't go for spectacles, and contact lenses are also not very useful. So in that case, hopefully, if the cornea is within the range, then hopefully we can offer a deep anterior lamellar keratoplasty. And I'm not a cornea surgeon, I'm an orbital oculoplasty, but in my experience, it all depends on the surgeon's hands. So that's why the corneal surgeon, certain people who do deep anterior lamellar keratoplasty, because it is a very technical procedure. You have to do this big bubble technique. You have to inject a big bubble inside a certain layer. There are 5 layers in the cornea, between the 4th and 5th layer. So that is some people have these like navigation microscopes, but only I think Jayapur has it, but other people do it blindly, but some people are good at it. So it all depends on the surgeon's experience, as well as the amount of keratoconus. The severe keratoconus, generally the prognosis might be not so good, but we can't really predict. Sometimes they come up with exceptional results, but then you have to be on the drops for kind of a very long period of time. Yeah.
I was referring to patient with vitreitis today and so because the mark was positive.
Right.
Now approximately 1/3 of the population will have a positive mark anyway.
Right.
How do you suggest that we proceed?
Well, to be honest, yeah, even for ophthalmologists, TB and syphilis technically, but it is not. Those are things that we can't come to terms with. We don't know what's happening. It can just come with a conjunctivitis up to retinal vein occlusion, to vitritis, to antechamber inflammation, and anything. There's the spectrum is so large, right? But in vitritis, most of the time, right, we don't find a reason. It might be MS, right? So we try to find a reason for it. So basic investigation what we do is, if it is vitritis, we have to investigate. Anterior chamber inflammation, just the iritis, we can treat and see. If it is recurrent, commonly it's HLA-B27, and very rarely is TB and syphilis. Or most of the time, 50% time, there's no diagnosis, so we can treat. But vitritis, we need to do the proper investigation, which includes TB, syphilis, sarcoidosis. So
It is a sample.
It is sample, but the whatever the outcomes are very low yield.
We have the facility to do the gene experiment.
Right.
Quite sensitive and gives a good result.
Right. But still, if you get to TB, now this is extrapulmonary TB, right? And the thing is, sometimes very the inflammation is not due to the infection, right? It's the inflammation sometimes, most of the time, or it's a combination. So the yield is very poor. So what we do is like we kind of treat it, give a, ideally speaking, I don't know whether you do this TB trial these days, like we used to.
For the CNS and eye,
Right.
consider the eye as a part of the
CNS, yes.
So, I mean, if you just request anti-TB, you will not hesitate at all.
Right, because there are certain things like scleritis, uveitis, like we are getting nowhere. Like, you know, the best chance would be just to treat with anti-TB and see whether it responds. Like it's a kind of blind procedure, and you can now. I don't know whether you have the gold TB test available.
In the
Private sector, yeah. So still, like you get 85 to 90% positive, but still you can miss the 10%. So the best way forward, I think, is if you don't have any other cause to treat and see whether it's responding, and like, you know, rather than going for steroid or anything, I think we should start the anti-TB treatment first, and within a day or two we can start steroids, because if we start steroids, like sometimes we can kill patients, the ophthalmologist, if it is a TB without monitoring, or a fungal thing, right? We don't know what it is, right? And then if we treat with steroid without the proper guidance, then it might end up with a cerebral abscess, and you know. So I think the best way forward is to give a course of steroid with the ophthalmologist's opinion. I think both parties have to get together and, you know, decide on it.
we not oppose.
Right. Okay. That's a good news for us.
Thank you, Kavinda, for your excellent lecture. I just want